And welcome to the Home of Medicine podcast, a podcast in association with the Royal College of Physicians, Edinburgh. I'm Dr. Amie Burbridge, and I am joined by
me. Hi, I'm Dr. Ben Lovell. Great to be back.
Ben. I've got a case for you. So I'm going to just dive straight in. Are you ready?
Yes, I'm ready.
Okay. So this is a case that I've seen many times over the course of my medical career. But I'm going to talk to you about one particular case that stays in my mind. But it's a recurrent presentation that I think we all probably see actually in acute medicine. Or in any medicine, to be fair. So I'm going to talk to you about a gentleman who's 52 years old, and he came to hospital with abdominal pain.
Okay.
He'd had abdominal pain on and off for 2 weeks, but it was getting progressively worse. The pain is located, he points to sort of epigastric, to be fair, he points to the middle of his stomach. So I often find when people say they've got abdominal pain, when you ask them to point it out, unless it's sort of like left or right upper quadrant, it's just a general, they sort of rub their stomach or rub their abdomen and go, it's all over. So sort of pain was sort of generalized all over the abdomen. It felt a little bit worse in the epigastric region. And actually said that the pain was very typical of his pancreatitis.
Well, that's useful. Case closed, pancreatitis.
Okay, so
listen to the patient. They're telling you the diagnosis.
Exactly.
He's obviously listened to the podcast.
So that's the end of the case. Thank you all for listening.
Bye.
Goodbye. No. Okay, so we've got a 52-year-old man with abdominal pain on a history of pancreatitis. Tell me what's going on in your head.
Okay, so what we want to be wary of here is premature closure and not saying, oh, hurrah, we've got a pancreatitis here. Let's go down that pathway. Keep our mind a bit open. We'll do our due diligence and let's take history and examine the patient. So he said, oh, it feels like a pancreatitis. I'm going to just file that for now. And then I'm going to come back to that with gusto in a bit. But right now, I just want to find a bit more about the abdominal pain. So things I'm going to ask about is, describe the pain for me. Sharp stabbing, colicky, makes you roll up in a ball into a fetal position. What kind of pain?
Okay, so he's first of all, as I said again, he said the pain is very typical of his pancreatitis. It's been there on and off for 2 weeks.
Yeah.
Although he did say that now it's getting better. So he's had it for 2 weeks, but it's getting better since it was over the last sort of couple of weeks. He says that the pain is very sharp in nature.
Yeah.
Feels like somebody's stabbing him in his abdomen or his stomach, tummy.
Does it go anywhere else?
No, not really. No,
Okay.
sort of. Well, it's just generalized abdominal pain. Doesn't point to one particular area. Slightly worse in the epigastric region.
Yeah.
Eating makes the pain worse.
Yeah.
He has not been eating because of the pain and is now only sipping water. He's not vomiting. He's not experienced dyspepsia. Although sometimes he dry heaves, but there's nothing to bring up because he's not really been eating.
Okay. So epigastric area is the worst. It's stabbing and it's worse on eating. So he's avoiding food and he's just sipping fluids. He's not vomited. Okay, you don't have to vomit. They usually do vomit with pancreatitis, but that's okay. And just thinking about what else it could be, is he got a peptic ulcer disease? But you told me there's no history of GORD, and he's not someone who takes a lot of NSAIDs or aspirin.
No.
And maybe we'll talk about alcohol intake, anything there. Okay, that might come out to the pancreatitis conversation, maybe. Okay. All right. And is his bowels opening okay?
So he's passing urine and flatus, and he's burping a lot. He's had no diarrhea, but he cannot remember the last time he properly opened his bowels for a good motion.
And is that normal for you, so when you have your flare-up of pancreatitis or your bowels stop working like that?
No, not really, actually. It's quite weird. I feel constipated. he
So that's
said.
a little ping for me. And what I mean
Okay.
there is we just want to make sure nothing's obstructed. So when people have nasty stomach pain that makes them vomit or feel like they can't eat, and before we make our diagnosis, you want to make sure there's not a plumbing issue and something isn't blocked off, twisted, obstructed, perforated, or otherwise stenosed or strictured. So if he's not making any kind of, he's passing flatus, but he can't the last minute bowel movement. Number one, is severe constipation a causative problem to this whole presentation? And that's why he's getting these terrible pains and can't keep any food down? Or is a constipation a secondary problem? And are we sure he hasn't got some kind of intra-abdominal pathology which is obstructing his GI system? So I'd be interested in things like abdominal distension, any new masses. Is his stomach bloated because he can't empty his stomach? And anything else, and then I'll have a good feel of his tummy a bit later. But anything from that point of view that might be obstructing him, any new masses or swellings or
He didn't comment on
distension?
any masses. His
Mhm.
stomach felt bloated. And he
Mm,
says that when he presses on his own stomach, because he thought if he
mm,
pressed on it, he might get him to poo, it
mm,
almost brought him to tears with the pain. And
mm,
actually, he said that sometimes when he takes deep breaths, in fact, it's
mm,
getting more difficult because of the pain.
mm. That's a little bit alarming, isn't it?
Mm.
I'm not, well, I don't get alarmed. That's a little bit, let's say, a little bit intriguing.
Okay.
But
Yeah.
it does make me think about, do we have to do some cross-sectional imaging of his abdomen just to make sure there's nothing obstructive
Mhm.
going on? All right then.
So, can I just stop you there, Ben?
Yeah.
What in that sentence that I just told you about him made you
Mhm.
think of obstruction?
When you first said he can't remember the last time he had a bowel movement, that's
Yeah.
atypical, I would say, for the general population. Not that we
Okay.
keep a diary of our bowel movements. So someone said, when was your last one? We could usually make a punt, couldn't we? The average person on the street. And then when you say that his abdomen feels bloated, and when he
Mhm.
presses on his bloated
Mhm.
abdomen, it causes severe pain. That makes me worry about gastric outlet obstruction. And is his stomach completely swollen and
Okay.
distended with gastric fluid? It'd be surprising that he hasn't vomited because that's got to go somewhere. Or that
Mm.
gastric lake, as they call it on OGD, that has to go somewhere. So if he's not been vomiting, that's unusual. But it just makes me wonder if something has blocked.
Yeah.
And he's belching, you mentioned, belching and burping, can't keep solids down. And maybe he'll start vomiting tomorrow or something. But that's what made me think about obstruction.
Okay. Okay. Yeah, absolutely. So to be fair, obstruction was also what was going on in my head. Well, that's the sort of thing
Mhm.
I was thinking of. Um, he wasn't aware of any fever, but
Mm,
felt very sweaty and clammy.
mm,
He wasn't sleeping very well because of the pain, didn't have any dizziness. Now, of
mm,
interest, he said around 2 weeks prior to this admission, he thinks he bumped himself when he was playing with his children. He denies any
mm,
fall, injury, or trauma, but he thinks that when he bumped his abdomen, and he's
mm.
really keeps coming back to this event where he bumped his abdomen and he cannot remember exactly what happened, but he thinks the pain started after this.
Mm. So it makes you wonder, what's he trying to tell us there?
Mhm.
Like almost subconsciously or consciously,
Yeah,
but he's trying to
yeah,
make some kind of point there, isn't he?
yeah.
That there is a correlation, a time
Mhm.
correlation between the incident. All right then. I mean, this is he. I do often say to patients, "What do you think happened then? What do you think's going on?" But it sounds like he already answered that question without being prompted. He said, "I think I've got pancreatitis," or did he have another theory that maybe needed us to draw out a little bit and just say,
Mhm.
"What do you think's going on with that bump you had to the stomach and now all these symptoms? Anything at all? Just help to give me a steer."
So he then said to me, I stopped drinking alcohol 2 weeks ago. And I feel that the pain came on then. And the reason I stopped drinking was because I had a fall and I think I fell or bumped my abdomen because I was
Mm,
drinking a lot of alcohol. And I've had a problem with
mm.
alcohol in the past.
Okay, all right. I think that opens up the door nicely to the next stage of past medical history. And at this point, I would be intrigued to find out about the pancreatitis. So,
Mhm.
am I right in drawing a line between the alcohol use and the pancreatitis before? Is it alcohol induced pancreatitis he's had? Okay.
Mhm.
Over
Absolutely.
what sort of time period are we talking?
4 to 5 years, he's
Mm,
had a diagnosis and recurrent admissions with chronic pancreatitis secondary to alcohol intake.
mm,
He's
mhm,
also known to be a cocaine user.
mhm. Hmm.
and has a background of anxiety and depression, although he denies any recent cocaine use. And by recent, months, I meant.
Okay. And he stopped drinking cold turkey 2 weeks ago.
Absolutely.
Did he go through withdrawals or not?
He said he's done it so many times that
Okay.
he just gets on with it. He knows when he
Okay.
needs to stop drinking. He stops drinking, manages the symptoms of it, and gets on.
Well done for that, I'd say.
Mm,
Not easy to stop. Not everybody
absolutely
gets
not.
severe withdrawals when they stop alcohol. I think only maybe something like a third of people who take alcohol daily actually experience withdrawals. So you don't have to go through withdrawal when you stop drinking. Um, and has he ever been diagnosed with any kind of chronic liver disease in the
No,
context of alcohol use? Okay.
no.
And medications, what's he taking?
Creon.
Yes, because he has exocrine pancreatic insufficiency due to the recurrent pancreatitis. Okay.
And omeprazole.
Okay.
And that was it, nothing else.
All right. And no allergies, I assume.
He's allergic to penicillin.
Oh, I assume wrong. You know
You
what they say
assume
when you
wrong.
assume. Yeah, yeah.
What made you assume that, Ben? What was going through
Mhm.
your head when you just went, I assume there's no allergies? Like,
I don't know. Maybe a desire to continue. I don't
but,
know.
but isn't
At
that
least I didn't.
interesting? Do you
At
find
least I double
sometimes
checked it. But I
you did
didn't.
double check
Yeah.
it? Do you find sometimes that when maybe you are maybe at the end of a day or it's been really busy and you go, so I assume no, you haven't got any allergies, and you
Oh
use
yeah, yeah, yeah,
negative questions instead of open questions.
yeah,
So if you
yeah,
say no chest pain, and they'll be like, oh no, but actually they have. And
yeah,
do you see what I mean when we use those negative questions? No chest pain, no shortness of
yeah.
breath, instead of saying,
I think I think that's okay sometimes
is it?
if you're using it in a conversation. Because you're saying you're not saying out loud, but you're sort of intimating, correct me if I'm wrong, but no allergies. Obviously one shouldn't take one's complete medical history like that, saying you've got none of these, I assume, because you are going to run into difficulties. But I suppose if you're doing it collaboratively with the patient and they feel able to interject you, you're not saying in such a forceful way, they probably think, God, he's saying all the wrong things here, but he sounds so busy and angry and important. I better not interrupt this doctor. So maybe there's something to do with bedside manner there as well.
Potentially, and I have to say, it's something that if I observe a trainee or a student doing, I'm like, no, that makes me feel icky. But then
Yeah.
I do it myself with patients. So I wonder
Oh, yeah.
whether is that
Yeah.
something that we learn to do during our career or that we feel more comfortable doing in our clinical
Yeah.
reason processes as we become more senior, potentially.
Definitely. And there's
I
a
don't know.
whole episode on it in isolation to do about that. Things we don't tolerate in trainees that we do all the time ourselves. Does that make us hypocrites or have we earned the right to bend the rules? Like driving with only one hand on the steering wheel or something. You don't tolerate that in a learner drive. So once you pass your test, people do all sorts of stuff, which I'm not saying is right. But I think that's sort of human
Mm,
nature a little bit. Certainly, when I'm working very quickly on my own, let's say I'm doing I'm covering an industrial action day and I'm acting as the clerking doctor. There'll be things that I do that I allow myself to do because I'm marking my own homework and I know what I mean and I know why I did it. Whereas if let's say a registrar presented that work to me, I'd say, I don't love that you cut a few corners here, it seems to me. Well, I didn't cut the corners really. I left that on purpose. But it looks medical legally in this note like you cut corners. So
mm,
there is a little bit of hypocrisy there. We do tolerate things in ourselves that
yeah,
maybe we want to go. We want our trainees to get it right before they start finding their own way through
mm,
life and their career. But we want them to meet the agreed standard of work before
mm.
they start deviating. And I think that deviation often occurs or we allow it to occur at CCT. Once
That's
you're a
interesting, isn't it?
consultant, you can do
Mm.
your own thing then. But until then, I would like you to do things the agreed way, keeping all the simple things done well and the basics, because that's training. Do you know what I mean?
So I do. I'm just going to challenge the. What do you mean by agreed way? Who agrees it? Like, what
Mm.
is the agreed way?
I suppose part of that is received wisdom of the ages, such as this is how we've
Okay.
always
Yeah,
done it,
yeah.
and this is how we should do it because this works and is tried and tested for many years.
Mm.
For example, if someone started muddling up the order of a history, for example, and started giving me social history before they gave me past medical history, I might think if a consultant, if I did it, I might think, well, I know why I did that. I had a reason, and this is. But
Okay.
if a trainee did, I said, you've got things back to front there, and that's not the
Mm,
agreed way we do things. And I don't think you're at
mm,
the stage in your career where you can start flying solo and changing
okay.
things up like that,
Mm,
because I want to make sure we don't miss things. I want to make sure you don't miss things. I want to make sure
mm,
you get things right for you and for the patient as well.
mm,
But this is me just talking off the top of my head. This is just my own meandering
mm.
stream of consciousness.
So, thank you for your stream of consciousness, Ben.
You're
Um,
very welcome.
I think we should. What else do you want to know now? So let's go back to our 52-year-old man with abdominal pain.
Yeah. Okay. So I think I've got a good history there. I was about to do social history, but you told me drinks, but 2 weeks ago, stopped. Occasional cocaine, but not for a very long time. And you mentioned children. And just who is he as a human being? Just help me see him as a person. What does he do? What's he like? What makes him a real person?
I'm really glad that you asked that, because I think when we understand an individual and we're curious about them as a person, as a human, I think it really helps us set the scene. It's almost like telling a story, isn't it? And I believe that what I've started to see is that lack of curiosity and interest. And I started to seep into medical practice. And I wonder whether that's because we're now so time pressured.
Mm,
One of the questions I love asking people, even if they're 96, is what job did you used to do?
mm,
Who do you live with? Or if I see a couple in their 90s and they're married, I'm like, how many years have you been married for? How have you stayed? So, how have you been married for so long? And you learn so much about people that I think that really helps set the scene and helps sort of tell a story. Because what we're doing when we take in histories is we're identifying their story, aren't we? We're building that narrative within our brain. And I guess what we're doing is building illness scripts, which is what we want everyone to do. So this man is on his second marriage. He has children from a previous marriage, and he's been married to his new partner for a few years. He works as a plumber, and he's been able to maintain a full-time job as a plumber throughout his issues with alcohol. He's never had a formal detox, but has always done that himself and has been successful. Um, he smoked many years ago, but hasn't smoked, for about 4 to 5 years. What's interesting is he describes himself as a clubber. And when he was growing up, he loved clubbing, and still likes to. I guess when I met him, I was really intrigued by he still had that vibe of being in that sort of era of Ibiza, of clubbing, of passion, nightclubs and stuff. And I got
mm.
that from him. It was fun. He was really fun to talk to, really fun to be around.
Wow. I mean, my clubbing days are well and truly
I
over.
mean, mine too. I
I'm a
don't think
bit
I
younger
really
than
ever
him.
had any.
I did in my heyday. One day I'll tell you all about it. I used to love the club. All right then. So I think I've got a good sense of who he is. And just to tag on to what you said before about humanizing people, it does help us keep them as human beings in our mind. It stops us talking about things like the abdo pain in bed 4.
Oh, I hate,
Um,
yeah, yeah, yeah.
but also it helps me remember them, because I work in a
Exactly.
specialty where I see a lot of patients in a
Mm,
shift,
mhm.
and at the end of a shift, I think, who on earth was that one? If I go, oh, that was that woman who used to live in Jersey and has the huge German Shepherd who knocked her over. Then all of a sudden, I remember them and I can visualize them very, very clearly.
Absolutely. Yeah. And that's how
Yeah,
I remember patients. It's not from the presenting complaint or the CRP.
yeah,
It's often, oh, that was the person who used to play for Wolverhampton
yeah,
Wanderers in the 1960s. And then you link it and you're like, okay, so that was where he came in. And
yeah.
I find that personally a much easy way to remember people. And like you say, it humanizes them, doesn't it?
It just sits in your brain. Someone says, "Oh, you know that patient you saw earlier, the COPD patient? I've seen 5 COPD patients today. That
Mm.
means nothing to me. And I'm going to, you're leading me down a dangerous path, but I'm going to get them mixed up and treat the wrong patient. So yeah, who was that person I saw earlier today?
Mhm.
Now, I think it's time to examine him, please.
Okay.
So looking at the end of the bed, how does he look?
Sweaty. And
Unwell?
actually, he looks unwell.
Hmm.
He found it difficult to sit down. And
Right.
when you see a patient and they're like, but they're standing up, sitting down, like quite agitated. And he said that
Hmm.
his pain in his tummy was so bad, he found it really difficult to sit
Hmm.
still,
Hmm.
quite sweaty, as I said. Um,
Hmm.
he looked to me, to my I was going to say untrained eye, but I guess I am trained by now.
It's very
Which
highly
is
trained eye.
highly trained, hopefully. He looked like he was withdrawing from alcohol.
Well, I did wonder. Yeah.
But he said he hadn't had a drink for 2 weeks.
Okay. What were his vital signs?
Respiratory rate was 18. Oxygen saturation's 99% on room air. Blood pressure, 95/72.
Okay, a bit low.
Pulse, 102 beats per minute.
Bit quick.
Temperature, 37.6.
Borderline.
Mouth
All
was
right.
clear. Yeah.
Yeah.
Chest was clear.
How did his hands feel? Peripheries?
Sweaty.
Cold?
Not really cold, and wasn't shaking, to be honest. You know, sometimes you see people who have delirium tremens, who are withdrawing from alcohol, are quite shaky, but he wasn't shaky, but he was just agitated in how he was walking around, but he said it was because of the pain. What was very interesting, he hadn't been given any pain relief because
Why?
Because substance misuse was well, I don't know, but substance misuse was documented in his history. And I sometimes feel that results, and we've talked about this before, in patients not being given adequate access to pain relief because they've had a previous substance misuse or have a substance misuse history.
And
I
the
don't
only
know.
relevance, really, if that is in history, is are they someone who regularly takes a lot of opiates? Because it helps you adjust the dose you need to give for pain relief to match their tolerance. But withholding opiates from someone who's in acute pain, I hope everyone listening to this agrees is completely against medical ethics, and we simply cannot do that at all. So I hope that wasn't the reason he had these painkillers withheld.
No, and I'm sure it wasn't. But I have certainly, over my many years of practice in variety of different places, have seen that discussed and mentioned and alluded to.
Yeah, so have I. Yeah, especially when patients asking for Oromorph, but has a drug. It's like, well, okay, you're doing a lot of pain. I think we're very suspicious when patients know the preparations of drugs. It's when people say, I need Oromorph, please, then makes you think, how do you know that name? How do you know that what that drug is? The average person doesn't. And I think people get a bit cynical. All right, so we've got a slightly sweaty, slightly tachycardic, slightly hypotensive man. It doesn't look great. He's not tremulous. He's not disoriented or confabulating. He's not in the grips of the DTs.
No,
and
definitely not.
He's a bit agitated and can't sit still because of pain. All right, fluid volume status assessment?
Well, he looked well hydrated to me, to be honest. His mouth was maybe a little bit dry, but I wasn't worried about.
Yeah.
His blood pressure was obviously a little bit low, but he didn't look to me like he was extremely dehydrated.
Right. Can I please palpate his abdomen? What did you find there?
He doesn't want you to do it, though.
I'm gonna.
You're going to do it. Okay. So, and I did. It very tender all over the abdomen, incredibly tender. Guarding in the umbilical region, para-umbilical region. I felt there was guarding in the lower quadrant of the abdomen, the right lower quadrant of the abdomen. But just to be fair, he was in so much discomfort that it was very difficult to palpate his abdomen.
What I'm thinking now, before I progress, is have we missed an acute abdomen? Should he have gone to the CT scan and possibly been discussed with the surgeons rather than coming to me, a bumbling physician? But let's press on. But I'm a bit worried about these abdominal findings now. I'm thinking about perforation. I'm thinking about obstruction.
Okay.
All right then. I had a really intelligent thought, but it's gone out of my head, so maybe it wasn't so intelligent. Any blood test results, please?
What would you like?
Let's start with is HB
12. 120. Sorry.
Yeah, 12 in old money. And it's
12 in old money. Platelets 104.
Oh, a bit low. And his white cell count?
12.2.
Okay, and his neutrophils?
8.
Yeah, not much to get too excited about there. Mild thrombocytopenia. Let's go to his U's and E's, please. So his sodium?
136.
So normal. His potassium?
5.4.
A bit up. Do you do urea?
We do urea. Yeah, it was 14.
Yeah. Oh, that's high. And then creat?
132.
That's a bit high as well. Now, I
Mm,
don't know the gentleman's baseline. You have not suggested that he has any kind of CKD.
no.
So I'm going to make an educated assumption that his creatinine should be baseline normal, and this is an AKI with an
Okay.
elevated creatinine and urea. And
Mm,
maybe he is a bit dry then.
mm.
And CRP?
221.
Nice. Okay. So a big inflammatory response there. Did you do a lactate on a VBG or an ABG?
We did do a VBG, yeah, and the
Mm.
lactate was 2.2.
So that's just borderline, isn't it? 2.2 is
Mm.
sort of the upper limit of normal, really, but is the altogether it doesn't look so good. So I'm going to summarize. I have a man here with 2 weeks of pain, abdominal pain, which has been getting worse, associated with bowels not open and poor oral intake, with a background of previous flares of alcohol-induced pancreatitis. He has, to me, signs of an acute abdomen with a very elevated CRP response and a borderline lactate and possibly an AKI. So my impression is going to be him writing as I think. 1, query acute abdo.
Mm-hmm.
2, likely AKI. 3, background of known ETOH induced pancreatitis. Did you get an amylase?
I did.
Yeah. Was it up?
1,084.
That's pretty diagnostic, actually. In my head, 500 is sort of this is not evidence-based, but in my own head and my experience, amylase of less than 500 can be a bit sort of nothing, really. But more than that, you are thinking about pancreatitis. So over 1,000, maybe there's still pancreatitis, but I still think it's time to scan him because has he developed severe pancreatitis, which is now necrotizing? Has he developed an abscess or a walled off area of infection, which requires source control, such as a surgical drainage? And what else? Could it develop to obstruction? I mean, I think that's enough reasons to get the CT scan. So my plan now is number 1, nil by mouth. Number 2, CT abdo-pelvis urgent. Number 3, start IV fluids. And because you say clinically he looks sort of euvolemic, but the AKI is up and he has not been drinking much, I'm just going to say 8 hourly to his Hartmann's to start with, because I'm not resuscitating him from a proof point of view. Now, what am I going to do about antibiotics? Mild tachycardia, 37.6, big CRP. Do you know what? I'm going to do that. Start IV cefuroxime, which is our broad spec antibiotic of choice in my institution. For now, revisit after CT scan. But he can have a dose now. Does he trigger for sepsis, as we say? Not really. No.
I mean, if you look at his
after CT.
observations, the lactates it was 2.2.
2.2, yeah. It's a soft trigger.
It is, yeah.
Revisit after CT. Number 5, full escalation. It's part of my general bump up in everybody's plan. Well, not full escalation, but I have a decision about treatment escalation plans.
Yep.
Full escalation of treatment, and then meeting all prophylaxis. I'm going to say yes. I think he's more prothrombotic. There's got no evidence he's hemorrhaging. That bump on the stomach is not anticoagulated. He won't have ruptured a spleen or anything there. Would he have had a retroperitoneal bleed with no coagulopathy? Did you have a coag on him?
Yes, we did. Coagulation was normal.
Normal. His platelets are low, but only 104. Yeah, VTE prophylaxis, please. And that's enoxaparin, 40 milligrams.
Okay.
And then that's 0.6. And 0.7 is, let's just do some CUR scoring, just to make sure we don't miss anything, but not to give chlordiazepoxide for now. Good. And then 0.8, review in 2 hours with above. There you go. That's my post-take ward round.
Okay.
How did I do?
It was very, very good, very comprehensive, but there's one thing that you missed off.
Okay, let me go back and look.
That it's probably too obvious that.
Oh. PR exam?
Oh, well, I mean, every patient should have a PR examination if required. No. What one medication haven't you given him?
Oh, here we go. Yeah, you're exactly right. Point number 9, analgesia.
Yes.
Can
Um,
start
mm,
with 1 gram paracetamol and Oromorph PRN. That would be 10 milligrams,
but
max 2 hourly.
you said you were gonna put him nil by mouth.
You're right, and I think 5 mils of clear fluids or more should be fine. If he was if that didn't work, I'd have no compunctions about offering him some subcutaneous morphine injections as well, to get him pain free. So, but I'll start with the basics, and then I'll reassess his pain and say, has that kicked in or not?
So what about if one of your differentials was
Hmm.
obstruction and perforated viscous?
Hmm.
So if we think he's obstructed or perforated and we give oral medication, will it work?
But you're asking if he's going to absorb anything.
Yeah.
It's a good point. He hasn't vomited, you said, right?
No, he said he feels sick, but he
No.
hasn't vomited. Dry
Yeah,
heaving.
yeah, yeah. I still think I would give a trial of Oromorph. Paracetamol we can give IV. It costs about £100, but we can certainly give it IV. And I would try with Oromorph. If you either vomited the Oromorph, had no relief from the Oromorph, then
Mm.
I would say let's give you parenteral painkillers for now.
Mhm.
But I think if you asked an ED consultant, they probably would go straight in with the
Mm.
injectable morphine route because that's their bread and butter and they're used to it. Whereas on the general medical wards, we're that's not our culture so much. We like to
Mm.
start low, go slow. But I wouldn't leave this man not reviewed for a period of time.
Mhm.
And it would be great if the Oromorph did help, and we could avoid giving anything that prevention unless we had to, because of course the onset and offset of the parenteral ones are quite quick. And if
Okay.
someone is reliant on boluses of IV
Mm.
morphine, for example, to get pain control, they work instantly. But experience tells me they tend to wear off all of a sudden. And it takes a heck of a long time to get your next dose because you have to ask for it. The nurse has to prioritize it. Then she has to double sign it out, draw it up, bring it over.
Mm.
And they tend to have more pain gaps like in between doses when they're reliant on IV preparations or parenteral preparations than the oral ones, which have more subtle onset offset times.
Mm.
So that's one of the factors into why.
Yeah, and I was about to challenge you actually before you mentioned the pain gap, and I think that's an incredibly good point actually, because I did and tend to go for intravenous pain relief in these type of patients. So I went straight for IV morphine. But you're absolutely right actually, is that pain gap can sometimes be quite big and it wears off quite quickly. So that's a really good point and I'll take that forward actually. And I
And
guess
it
what
can
we
be a really bad one as well because
yeah,
when it wears off with a thump.
yeah. And I guess that we should start to think about patient-controlled analgesia, PCAs, which we don't use enough, I don't think.
Well, that is partially because it's a big training intervention to get everybody ready to look after
Mm,
PCAs. We don't have them in our AMU because it's a big burden on nursing times, and you really need a nurse who's sort of like 2-to-1ing a patient to make sure that they can manage the PCA. Whereas, we have 5-to-1 nursing ratio like any medical ward. So
mm,
partially, it's about making sure doctors are trained up in safe prescription of it, knowing the indications, contraindications, and that's very difficult in the world of rotational medicine because you're
mm,
constantly teaching new doctors, which is not their fault, obviously, but also you
mm.
need a nursing and a pharmacy workforce who are able to meet the demand as well.
Good points. Okay, so where are we now? What investigation do you want to do? What's your plan?
I want that CT scan, please.
Okay, what do you think it's going to show?
Let's say I think it might show something like severe necrotizing pancreatitis
Okay.
with impending obstruction of the
Yeah.
part of the duodenum and a collection. I don't know. This is all stuff that could cause severe pain and
Yeah.
abdominal distension.
Yeah, absolutely. Okay, so I'm going to tell you what the CT did show.
Yeah.
The CT showed perforated
Okay.
appendix.
Do you know, I wondered about that when you said right
Mm,
lower quadrant. And I remember all the way back from medical school, appendicitis starts off with central abdominal pain, which then migrates down to the right
mm,
lower quadrant.
mm.
Um, when the locally because it starts essentially because the embryological
Embryological
remnants are
origin.
the midgut,
At the midgut, yeah, and the
so it
hindguts.
radiates to the umbilicus. But then, as local inflammation becomes very severe, you get local pain in the area of the appendix in the right lower
Mm,
quadrant. So that did flip through my brain,
mm.
um, and we did this. Well, not we, but I'll use the passive voice. An acute abdomen was missed on this occasion. But thank goodness they met a clinician who was able to make the diagnosis.
Mhm.
And I think the antibiotics therefore would have been helpful. Yeah, that's really interesting. So what happened next?
It is really interesting, isn't it? And what happened next is I picked up the phone and spoke to my surgical colleagues and said, I have an
Yeah.
acute abdomen. Are you able to come and review? This gentleman's got a perforated viscus. He's got appendicitis,
Mm.
which happened. Patient had his appendectomy. He was fine.
Mm.
What interested me about this case, and I think this is a point for discussion, is that this gentleman, when he came in through the emergency department, had been referred to the surgical team.
Oh,
They didn't see him because it would just be his normal alcohol-related pancreatitis. It
right,
must be.
right.
So they don't need to see
Yeah.
him.
It's I'm always mindful
Mm.
that I don't become overcritical of
Yeah,
colleagues
yeah,
without knowing the full story, because I've learned that lesson to my detriment over the
me
years in
too.
my
I
career.
agree.
I've flown off the handle before and I've fired off emails and all sorts, and then it comes back that actually, Ben, you were not in possession of all the facts and you actually look like a bit of a wally now. So I try not to. And at the same time, that's a shame that that
Mm.
happened to that man. I wonder if could this be over reliance on is it good old Osler who told you the patient was telling you the diagnosis?
Yeah,
Uh,
potentially.
maybe it should be listen to the patient. They are trying to tell you the diagnosis rather than they
They
are
are
telling you
giving
the
you the
diagnosis
information that might help
for
you
you to make
formulate
a
a
diagnosis.
diagnosis. Yeah. And you're
Yeah.
absolutely right. If you've got a patient who comes into hospital and says, I'm in pain, it feels like my pancreatitis.
Yeah.
At what stage do you go, oh, okay, it must be pancreatitis? Or do you go, oh, let me
Yeah.
just ask you a few more questions? Because sometimes I've tried that and the patient's gone, but I'm telling you what it is. I just want
Yeah.
some
Yeah.
pain
Yeah.
relief. And I'm like, okay. So
Yeah.
it just, I guess, makes you think about how much do we challenge that initial diagnostic
Yeah.
diagnosis from the patient when they're telling us what it
Yeah.
is.
It's
Um,
premature closure, as I said at the beginning.
it is
Where I
premature
see this a
closure.
lot is with chest pain. And it's when someone comes in with chest
Mm,
pain, which is super atypical. It's on the left. They've got a tender chest wall.
mm,
Their ECG is normal. Their troponin's normal. Their chest
mhm.
X-ray is normal. Everything's fine. You can reproduce the pain and palpation. And they say to you, but this is exactly what happened when I had my massive heart attack in 2024. This exact
Yeah,
presentation. And that means something, I
it does.
think.
Yeah.
And sometimes that changes my mind. Sometimes that makes me
Mm,
move from discharge to ambulation or even admit for observation sometimes.
okay. Yeah.
When the patient is saying, I'm telling you, this is exactly how it was before. I know it's atypical, but this is typical for my previous heart attack. And I'm terrified I'm having another one. And that's the context I see it in sometimes. You must have seen the same.
Yeah, and absolutely. Chest pain in particular is one where well, this is the same as my last heart
Yeah.
attack. So I must be having a heart attack. And I'll be
Mm.
like, oh, okay, but everything's normal, like everything was normal last time.
Yeah.
Okay,
Yeah.
so what do I do? Do I,
What do you do? Yeah.
yeah, do you, and I tend to admit, because
Yeah.
the patient's usually right,
Yeah.
particularly when it's something as serious as this. I'll say, okay, we'll admit, we'll observe you, we'll do ECGs, we'll do another
Yeah.
troponin. And sometimes, yes, they absolutely are right. They do have a
Mm.
blocked LAD
Yeah.
or a circumflex. And I'm like, oh gosh, their
But
troponin was
sometimes they're
normal.
not though.
Sometimes they're not. But isn't that
I think
medicine?
I think if it when it's happened more than once, when you
Yeah.
have a recurrent attender and they keep getting seen,
Mm,
although there is good evidence that these recurrent attenders do come to harm at the end of the day because
mm,
things get missed. But I certainly have said to patients before, I hear what you're saying. This feels exactly like the pain you had with your heart attack.
mm,
I think it's very reasonable that the body keeps the score. Your body remembers that
mm,
pain and is being reproduced this time. So it's very natural you think that. And that's why I've been so careful today. And I've done
mm,
all these extra tests. I'm so reassured by the
mm,
tests. Whilst I know you're having pain in keeping with the same kind of pain you had with your heart attack, you are not currently having a heart attack. And I really hope that reassures you a little bit. And I
mm,
have done that before and discharged patients, or at least ambulated them, i.e., sent them home and booked them into for a follow-up appointment in ambulatory care in Estec
mm,
a day or so later,
mm.
and given them the emergency number and all of this sort of thing, safety netted my head off. But I think that's brave, and I'm not always in a brave mood, and I don't
Mm,
expect the resident doctors that I'm training to be that brave and to know how to make that decision. And that's why I always say when I'm on post statement, I will never tell you off for admitting a patient,
no,
because obviously you thought that
absolutely.
was safe, because they present patients pre-faced with, oh, this was a really soft admission, I'm really sorry about this one. So you
Mm,
never have to say that. Please don't say that. So
mm,
now I'm already thinking this is going to be nothing. You've influenced me.
mm,
Let's just be
mm,
robots and present the case, and I'll reach some
mm.
conclusions and ask questions at the end. But I'll never
And
give you a hard time.
what you alluded to there was that Daniel Kahneman labeled it as noise. Um, the noise in the decision making process that
Mhm.
we often it's around us, but we don't really know what it is. So, for example, it's a Friday afternoon, or it's a Sunday morning at 4 o'clock, or it's
Mm.
really noisy, or I'm really hungry, or really tired. And we've talked about this before, actually, where our own inner mood, feelings really affects how we make decisions.
Yeah, of course. Otherwise, we wouldn't be human beings.
Exactly. So, I've been in situations where I have seen trainee doctors, locally employed doctors being sort of, I guess, not pulled apart, but really questioned as to why they did this, why they did that, in a
Yes.
way that makes me feel uncomfortable. And I'm like, let's just take this back a bit. This was 3 o'clock in the morning. They were exhausted. Nobody wants to be awake at 3 o'clock in the morning. Our cortisol levels are really low. I don't think we should ever criticize people who practicing in a way that they think they're doing the right thing at the right time. They're not deliberately making bad decisions or doing things that are incorrect.
Yeah. No, I completely agree. Um, and if we are giving residents a hard time, I don't want to be all touchy feely about it and saying we can only ever
Mm.
give positive feedback and shower them with praise, because I don't think that's respected amongst trainees. I think trainees, they want to hear what could they do better next
Yeah,
time.
absolutely.
And
Yeah.
I think people I respected when I was learning were people who would give it to me kind of straight but kindly, and say things like, look, I appreciate your reflecting, Ben, that things didn't go the way you would have liked in this case. Let's work out what you're going to do next time to make it go the way you want.
Yeah.
And I think that is welcomed by most people, but maybe trainers, we're not so great at saying it.
Mm.
And as for the handover viva in front of a room full of
Ah.
people, that should have gone out with the arc. And what's interesting to me is that the GMC survey every year, which is an incredible, in one of my roles as the deputy director for education at my trust, and GMC is a massively powerful tool that gets
Mm.
analyzed to death, both external to the trust and within the trust
Yeah.
itself, gets sliced and diced and looked down at every answer of 2 decimal points and really analyzed. And we have to make answers for every bit.
Mm.
One of the questions they ask is handover. Do you find handover to be an educational
Yeah.
experience in your trust? And I've always puzzled over that, because
Mm.
what does educational handover look like? If
Mm.
someone's coming off the dregs of a night shift and all they
Oh,
want
I
to do is
know.
go home, and I launch into a mini sort of seminar, they're going to want me to die. I would have done.
I
But
know.
and again, if you ask a few sort of educational Socratic questions,
Mm.
again, people are going to say, I can't, I'm
I'm
exhausted.
too
Let me.
tired. Yeah, exactly.
So I still haven't quite cracked that. So if anybody knows what an educational handover looks like that people
Mm.
actually like, please write your answers on a postcard and send them in, because I'm still trying to crack that particular nut after 20 years in medical
Mm.
education.
Yeah, and I've been asked on many times to try and make handovers educational, and I've tried
Yeah.
lots of different ways of doing it. Here's a session on, I don't know,
Yeah.
DKA, and these people just want to go home.
Yeah.
Like,
Maybe just
I get
message
it.
of the day or something. You
Yeah,
know,
one thing. What's the
one
one thing that I want you to
sentence.
take away today
Yeah.
is, I don't know, neutrophils is spelt N-E-U-T. There's something really simple
Oh,
because
you're
actually
keeping it low.
I'm keeping it
Keeping it
really,
simple. Yeah.
but I can't take anything on after
Mm.
13 hours at work,
Yeah.
let alone a physiological concept. So
No.
why do we expect our trainees to take that on? I think
Yeah.
handovers are for safety of the patient,
Of
safety of
course.
the doctor to make sure that they are okay before they go home and they're
Mm.
not being harmed physically or mentally by what's been happening. But I think trying to force enforce education in a way it's not a natural educational environment. I learn from handovers just by listening to what people are saying, rather than saying, list 5 causes of fever, which is just never going to.
No. And I remember that. One of the
Yeah.
only times I ever cried at medical school was at a handover like that from an
Really?
orthopedic surgeon who said to me, right, name 3 causes of acute renal failure after hip replacement surgery in front of a room full of people. And I completely choked. I had nothing to say. And the things he said to me, are you sure you're a medical student? Do you really think you belong here? All that kind of stuff. And it's the only time I went into a toilet cubicle and had a cry. Never again.
God.
But I have very strong feelings about that.
Yeah. And it's just not the way that, well, it's not teaching, is it? That's just humiliation.
No, I was humiliated. Yeah.
Yeah, exactly.
Yeah.
Thank you very much, Ben. Loads of learning points there. So maybe in the handover, our podcast should just be in the background. So it's like you could learn via osmosis.
Mood music.
Mood music.
Shut those bloody idiots up with this fucking handover and go home. Yeah.
Right. So again, Ben, thank you as ever for your fantastic insights into the world of acute medicine. Thank you very much to everybody who's listening. Please rate, review, and subscribe to the podcast. We are doing so well with our numbers and downloads. Like, it's just crazy how impactful the podcast is. So we just want to keep growing and growing and growing it, just so as more and more people can learn something or take one little nugget away from this podcast. A massive thank you to everybody who supports us, and a huge, huge thank you to the Royal College of Physicians, Edinburgh. Thanks for listening. Goodbye.
Take care.